Hi, everyone. My name is Emily Duggan, and we're pleased that you can all join us for our first lecture in Volume 3 of our 12-week No Neuropsychology Didactic series that brings you lectures from experts in the field covering different topics each week. This series was created by trainees and early career neuropsychologists to provide free, high-quality didactic opportunities. And it's hard to imagine that we just launched No Neuropsychology less than a year ago with our first lecture on April 20th, 2020. And today we have officially surpassed 2,500 subscribers. So thank you all for being here and being part of this. We would like to thank our sponsors and their financial support for the series. And before we start, here are the disclaimers for the series. This training is not meant to replace formal education in neuropsychology, and the views of the speakers are their own. For those of you who have questions, you can submit them via the Q&A box in the lower left or the lower middle of your screen. And a recording of today's lecture will be provided on our website later this week. All right, now it's my pleasure to introduce Dr. Robert Heaton for today's lecture on cross-sectional and longitudinal norms in neuropsychological decision-making. Dr. Heaton's research uses refined neuropsychological methods to characterize cognitive changes associated with numerous conditions, including focal brain lesions, Alzheimer's disease, multiple sclerosis, schizophrenia, substance use disorders, and HIV infection. He's published extensively on the neurobehavioral effects of HIV infection and comorbid conditions, including substance use disorders, as well as on the use of neuropsychological testing to document changes in brain functioning due to disease progression and treatment. This work has been done in the US and multiple international locations. He also has chaired the algorithm committee that operationalized the international Frascati's criteria for research classification of HIV-associated neurocognitive disorders. These included criteria for classifying neurocognitive impairment, symptomatic status, and 3 levels of comorbid conditions. In more general neuropsychology work, he has demonstrated the importance of correcting for multiple demographic influences on the test performance of normal subjects and published demographically corrected norms for many widely used tests. A long-standing interest has been to establish the clinical significance of neuropsychology test results. He has done so in numerous studies demonstrating strong associations between neuropsychology findings and disease prognosis, patient capabilities and limitations in everyday functioning, and postmortem neuropathology findings. Dr. Heaton has received the National Academy of Neuropsychology Award for Distinguished Career Contributions. He is past president of the Clinical Neuropsychology Division of the American Psychological Association and the International Neuropsychological Society. With great pleasure, I'd like to introduce Dr. Robert Heaton. Thank you for joining us, Dr. Heaton.
Okay, thank you, Emily. I'm very pleased to be here. I was telling Emily before that I have 60 slides. Some of them should go by very fast. I think we can get through them in 60 minutes, but I'll try to save some time at the end. And if I'm going too fast, I hope Emily or somebody will ask me to slow down or something, and I'll do my best. So here to start, these are the 3 goals of neuropsychological assessment. The first one, of course, is to detect and classify acquired neurocognitive impairment due to injury or disease. Secondly, we use our tests to measure changes in cognitive functioning over time, either improvements after an acute insult to the brain or in recovery or treatment effects, or decline with progressive illness. And the third one is predicting everyday functioning, but I won't be talking about that today. I will try to address the use of norms in these first 2 with these first 2 goals of neuropsychological assessment. Next. Moving on to the expanded Halsted Rayton battery, and the nature of these tests really doesn't matter, and I'm not going to spend time on it. People use different measures, but they all show these kinds of effects in my experience. For the expanded Halsted-Rayton battery, we had 634 non-Hispanic whites in the top group, and 578 African Americans in the bottom, and they are similar in terms of average age and education, and there are a few more males in the Caucasian group, but they're not very different demographically beyond the race ethnicity. Next. And this, I apologize for the next few slides, and they're because they're very busy and hard to look at, but I hope you can see them. What I'm going to do is I'm going to focus on the top line here. This is the core Halsted-Rayton battery, and one of the best summary scores is the average impairment rating, and these are uncorrected scores. And it shows for the Caucasian group, the percent of people that are normal people that are correctly classified as normal. For the young folks in less than 40 years old on the left, and in the middle, 40 to 59, and then 60 plus, and then the total. And the total's not too bad, it's 82%. And you're getting everybody in the young group, and you're getting fewer than 50% correctly classified as normal in the 60 plus group. Next. And this shows the same thing, actually opposite pattern for education, where the high school dropouts, more than half are misclassified, and more than 90% are classified as normal in the college graduates. Next. And then for the African Americans, you see exactly the same pattern, where young people have the highest specificity, but the older ones very poor. And for the African Americans, these are uncorrected scores, and the total correct classification is low, just like what we saw with Way-Swims. Next. And this is the same thing for education level. Next. Okay, so let's look at Halsted-Rayton battery again using the average impairment rating, and see what happens with raw scores versus fully corrected T-scores. The T-score, as I'm sure you all know, is a mean of 50 and a standard deviation of 10, and it's so a cutoff of 40 would be a 1 standard deviation cutoff. High is good for T-scores, and high is bad for average impairment rating raw scores. So next. So here we have in the red lines the normative sample of, and it's divided into 3 age groups: less than 40, 40 to 59, and 60 plus. And for green, we have 390 people with documented structural brain lesions with imaging and/or neurosurgical report. And you can see for raw scores, again, high is bad. And you can see that as people get older in both of these groups, they're showing a substantial linear age effect, like we saw with the Way-Swims factors. And the difference between the two lines, though, the red and the green, is your brain damage effect. On the right, you see the T-scores again here. High is good, and 50 is expected. And for all 3 levels of age, the means are 50. And down below, you see the brain damage groups. And so there's not a significant age effect for either one, and there's a very substantial brain damage effect. Next. And this shows the same thing for education levels. So the higher the education, the lower the raw average impairment rating, and but for the T-scores, they're flat. Next. Okay, just recently, we have published a special issue of the Clinical Neuropsychologist describing a normative study providing demographically corrected norms for native Spanish speakers in the living in the U.S.-Mexico borderland region of Southern California and Arizona. And we had 254 Latino adults here. And again, we corrected their results for age, education, and sex. And then in the next slide, you'll see we applied them to the normative sample and to a sizable group of Spanish-speaking HIV-infected people. So next. Okay, so the green bar is what you'd expect for the normative sample. And of course, that's the norms are based on them. But when we applied those to the Spanish-speaking HIV-infected people, you see a substantial HIV effect, which is similar to what we've seen throughout the US with English speakers and also around the world with other languages. Next. So we also wanted to ask whether background characteristics other than the basics, age, education, and sex, might have been important as well. And so here in the middle column, we have we're looking at global mean scaled scores on our HIV battery that covers 7 basic ability areas that include verbal fluency, processing speed, attention, speed of information, attention working memory, new learning and delayed recall, and executive function and complex motor function. So the first 3 of these are just our basic demographics, and it shows for global scale scores that are uncorrected. Older age is associated with worse scores. Males did somewhat better, and higher number of years of education was better. But all of those effects went away on the global mean T-score, which is as expected, right? So those are the red X's show that they're not important anymore. And we also thought it might be important whether the folks were gainfully employed now, and that did not matter for either type of score. We asked some more details about educational background. One of the things we asked about was whether they had how many years of their education, what % of their education was in the country of origin, which virtually always was Mexico. And that was important for scale scores, but the effect went away with the basic demographic corrections. We asked as well whether the schools that they attended had good physical resources, and this would be things like having just one grade in a classroom and having enough space in the school environment to have recreational activities going on as well. And you see that both for the scale scores and the T-scores, having good physical resources in their school environment was a positive thing, and maybe that's something that should be considered in further refinement of norms for at least this population. We also asked the number of students in the classroom, which did not have an effect. We asked whether people had to stop going to school in order to work to support the family. And that was a factor for scaled scores, but again, the T-scores pretty much took care of it. Next. We're interested in other aspects of their childhood background. Mothers having a mother having higher years of education and father also was associated with better scaled scores, but that was corrected by the basic demographic corrections. We wanted to know whether more time living in the country of origin, again, Mexico in this case, would matter, and it did not. This is subjective, but we asked them whether they in their opinion, their family was very poor when they were growing up, and that was a factor for scaled scores, but again, not for T-scores. We asked about whether their home environment lacked basic resources such as electricity and running water and sufficient food supplies. And that was a factor for both raw scores and T-scores, and something that we should make note of in future work with really with any population that may have had adverse childhood experiences in this way. We asked whether, in their opinion, they had poor physical health when they were growing up. Again, it was important for scaled scores, but not T-scores. Interesting. We asked if they worked outside the home for their own, to better themselves, for their own benefit, and that was associated with better performance on the scaled scores and even better T-scores. We asked if we looked at the age at which they had to start working as a child, and that was not a good thing for scaled scores, but again, the T-scores corrected for that effect. Next. And finally, we were interested in language background. And we assessed this in three ways shown here. One is we asked the participants whether they felt their English was better than their Spanish comprehension and fluency. And then we asked also whether how much currently they used English in their day-to-day living, and both of those were associated with better performance on the scale scores, but corrected by the T-scores. We also asked the same thing for the examiner, and again, it had an effect for the scaled score, but not the T-score. And finally, we did a performance-based assessment of bilingualism, where we simply took, for English, the phonemic fluency with letters F, A, and S, and we gave the Spanish fluency for the letters P, M, and R. And our measure of bilingualism was somewhat arbitrarily, but we've used it before with good effect. And it was the percent of the FAS plus the PMR that were English. And if it was 60, 2/3 or higher, we classified them as primarily English speaking. If it was 1/3 or, and we didn't have anybody like that, by the way. If it was 1/3 or less, we classified them as primarily Spanish speaking. And if it was in the middle between 1/3 and 2/3, we classified them as bilingual, and bilingualism was important for both. Next. Okay, so we've done a lot of HIV work around the world, and these and other countries, the US around the country, and then other countries. On the left, you see 4 bars showing the percent of HIV infected people in these places that were classified as impaired using well-established, demographically corrected norms that we've developed first in the US, and then the next 2 are in 2 Chinese provinces, The Anhui is a very poor province with very low education levels, and basically agrarian area, and Yunnan is more well-to-do and higher education and so on. And then Zambia in Southern Africa. And we published all of those. And then on the right, we have 4 other places where we had done some work, but had not had the opportunity at this time to develop adequate local norms. So we had to either use the US norms or much smaller samples. And you see there's a lot more variability here. We do not think that the HIV effect is higher in these places because every place where we've been able to do the norms right, we've shown good consistency. Now we're just in the process of publishing much better South African norms. Next. Okay, why do we pick the 1 standard deviation point as a cutoff? Because that means you're willing to be wrong in 15% of normal cases or so in calling them impaired. Next. This is a cartoon that shows that there's a trade-off between sensitivity and specificity, and that's partly because there's a overlap in people with no history of any kind of risk factor for neurocognitive impairment, and the green here, and people who have documented brain lesions. Again, this is a cartoon, and the red. And in the middle, you have the cutoff of 1 standard deviation. And so you see a really good balance here. I'll show you some real data in a minute that look like this. And then on the bottom frame, you see if you move your cut point from 1 standard deviation to 2 standard deviations, yeah, you pick up some of the green people, but you lose a lot more of your sensitivity in the impaired population. Next. So I would suggest that these as guidelines for how to pick your cut point. And with T-scores, you can pick it wherever you want to, but just be aware that there is this trade-off. So I would suggest that specificity must be reasonably high because norms are all about specificity. And I suggest it should be more than 80%. Secondly, that false positive and false negative errors are both bad. So they should both be as balanced as possible. And secondly, and thirdly, we would like to be correct as often as possible. And this one is more complex. I'm not going to get into it, but it may depend upon the nature of the population you're working with, and whether you're and the kinds of neurologic disorders you're looking at. If you're looking at moderate to severe Alzheimer's disease, you can make your cutoff a lot more stringent, and you'll probably still get all of them. Next. And this is the actual data from from the Halsted Rayton battery, the average impairment rating and their T-scores. And in the red, we have the brain damage group, and the green, you have your normal group. And it looks a lot like the cartoon. There is overlap. There's no point you can pick that gets everybody right. And if the best place to balance sensitivity and specificity does end up being the 1 standard deviation cutoff. Next. And this shows just the cumulative frequency distribution of the brain damaged people in red, and the normal people in green, as the T-scores on the x-axis move along from severe to above average. Next. So we've been talking about use of norms for a single test measure. But what happens if you give a battery with a whole bunch of tests? Next. This is data from the neurologically normal people in the expanded Halsted Rayton battery that had at least 25 measures from this battery. And you see that on the x-axis is a number of abnormal scores. So only 13% of the people had no abnormal scores. So most of us are not perfect, and the more tests that one gives us, so the more likely we are to screw up on one or more of them. And it turns out that for these, as far as we can tell, completely normal people, they screwed up on the one standard deviation level for about, on average, 10% of the tests. Next. A way around this multiple comparison issue is to use what we've called a global deficit score approach. And here we begin by having the demographically corrected t-scores for all the tests in the battery. And then we classify each one as normal if it's one standard deviation below the mean and better. And 85% of your normals are going to be there. And the deficit score is 0, no deficit. Doesn't matter how normal it is, it's no deficit. And that's like what a clinician does, both a physician and neuropsychologists. We do tend to pay more attention to impairments or abnormal findings than normal findings, things within the normal range. We put more weight on them. And when you have just a whole bunch of tests and you're looking at the whole array, what you have to do is, of course, pay attention to the number of impaired ones and how impaired are they, and also what their pattern is in terms of the strengths and weaknesses that are expected to be associated with the kinds of disorders that you're trying to detect. But with the global deficit score, it tends to work more broadly. And so if a person has a t-score on an individual measure of 35 to 39, we call that mild. 8.6% of normals will be there. So that's a 1. Deficit score of 1, a mild to moderate. 30 to 34, 4% are there, and that's a 2. And beyond mild to moderate, you get into the moderate impairment and worse, you're virtually out of the normal range. So if somebody does that badly, you're very unlikely to be incorrect to say that they have an acquired impairment in that area. Next. And this just shows for the full scale IQ in orange here, and for the average impairment rating in blue, and the global deficit score in green, the cumulative frequency of people in the brain damage group that were classified as impaired on the y-axis, and the cutoff of mild impairment of less than 40 is right in the middle there. And you see that GDS gets, of all these diverse neurologic conditions, they get over 90% accurate. Next. And we use it for all of our HIV work too. Regression-based norms for change. Now we're going to the second use of norms now. And here the question, of course, is how much of a change in test performance is real and represents a real change in the individual versus normal test-retest variability. And so for this, we ideally need to account for practice effect, regression to the mean, their baseline level of functioning, the reliability of individual tests, which differ from test to test, and of course, demographics. Next. So what we did in our HIV work is we developed a sample of 296 clinically stable people with 3 to 6 visits, either with a test-retest interval ranging from 6 months to 2 years. And we had 172 HIV negatives and 124 that are carefully classified as clinically stable HIV positive people who are well treated. And they were not different in terms of how their test-retest results varied over time, how their change varied. And we use as potential predictors of follow-up scores for each individual test measure, the baseline or prior visit score on that measure, the overall neuropsychological competence at baseline, which is defined as the average of the scaled scores, uncorrected scaled scores that are normalized on all the other tests besides the one you're looking at. We looked at test-retest interval, and we looked at demographics. And so this accounts for all those predictors, many of which are not accounted for by things like the GDS. And we can also measure degree of change both within the normal range and within the impaired range. Weaknesses, we had limited data on potential changes beyond 6 visits. And obviously changes in the normal range may not be all that important. We just don't know, but we have the ability to look at it. Next. So the way we do this is for each test measure, we do multivariate regressions predicting the follow-up scores from all the things that I just mentioned, baseline scores, competence, et cetera. And then you subtract the predicted follow-up score from the observed score and divide it by the standard deviation of the residual of the regression equation. And that gives you a z-score that tells you how well or how poorly the person did based on what would be expected if they weren't changing. And then if you average those z-scores, you have a summary regression-based change score. Then you can look back at your normative sample and make cutoffs for 90% confidence interval is what we've used, but that's arbitrary. You could use something different from that. Next. And so for this normative sample here, it shows the distribution of these regression-based z-scores from time 1 to 2, 2 to 3, time 1 to 3. You see they're pretty well distributed. Next. And then we applied this to 438 longitudinal subjects with HIV infection around the country and on a multi-site study that we coordinate. And so all of these people had at least 4 visits, and there were 2,680 visits altogether. We stopped it at visit 7. Next. And this shows that we had about 23% of the infected people declined, 61% stayed the same, and almost 17% improved. And next. This shows that at baseline on the left, these 3 groups, the decliners, the improvers, and the people who were stable, were essentially the same. And you see that the average T-score was lower than 50 because these people, many of these people do have some HIV-associated impairments. But the 3 groups really fan out to the last visit. So the decliners in the red really are a lot worse than the others. Next. And this shows that when you do that, when we did that, we looked at these HIV infected people and classified them as whether throughout the longitudinal record, they always had detectable virus in plasma versus sometimes versus never. And you see the ones that consistently had virus in replicating virus in plasma their summary regression change score was much worse. So 0 up there is completely no change. And next, then we looked at all the things that might also predict decliner status. And here we're looking for time-dependent predictors that have asterisks, and we're estimating time to neurocognitive decline. And the factors that mattered were Hispanic ethnicity, and we can talk about that if you like. Having more severe comorbidities besides HIV, being off if you go off your antiretroviral therapy, that's a bad thing. Having a low albumin and low hematocrit, which are general illness indicators of that are often associated with infection and inflammation. Having lifetime diagnosis of methamphetamine dependency, and having more depression. And the overall model was very highly significant. So next. That's it. So I told you I thought we could get through them, and I see we have some questions, so we have some time to do that.
Great, thank you so much, Dr. Heaton. I would like to echo what we're getting in the chat, that this is just such a rich lecture with a lot of history and background, and I think I speak for so many that we're very appreciative of all of the work that you've done to contribute to really the foundations of neuropsychology of what we do today. So thank you for joining us and for that great lecture. I'd like to start with a couple questions in the chat here. One is related to, everybody uses kind of different labels and norming systems and kind of ways that they think about things. And there's been efforts recently to kind of create uniform labeling. And I think, a lot of our attendees are students who are just kind of learning about these issues. And so what can you say to students who are kind of wondering about how recent changes in more uniformed labeling impact our understanding of the norms and the data that we have now?
I think, standardization, obviously I'm all for it. And as long as, but some differences are also okay, as long as they clearly define what it is that they're doing and using, so that it could be replicated or compared with what other people are doing. But I have nothing against trying to standardize, because we've been working on standardizing approaches to HIV-associated neurocognitive disorder for a very long time, and there's always resistance for some groups being encouraged to use criteria and definitions that are developed by other groups. In the HIV area, back in 2005, we had a big international conference outside of Rome where people, multidisciplinary HIV researchers around the world came together to hammer out some standardized approaches, because before there had been approaches that were unclear and not standardized, and people were using the term HIV-associated dementia to mean anything from the slightest impairment to true dementia and so on. So we did that, but we came up with a complicated system that a lot of people don't like to use, but there is more consensus that the global deficit score approach can be very helpful.
Sure, absolutely.
I don't know if that answers your question, but
I think that's a very great comprehensive answer. And I agree that, labels at the end of the day, they can change across settings and use, but the statistics still have the fundamental same meaning underneath the labels. All right. There's a question that's kind of more generally getting at um, if you can add any more information about the general differences between African American and Caucasian individuals within the Heaton norms, just to paint a more thorough picture for
Well,
people.
their demographic characteristics and in terms of age and education and all that are not that different. Some of the effects. If you look in the manual, there's a table that shows a couple tables that show what the education effects, the age effects, and so on are for the two racial ethnic groups, and they're somewhat different. And then when we went to norm the NIH Toolbox Cognition Battery, also we did separate corrections for the other demographics for different racial ethnic groups because the effects are different. They're not hugely different, but they are different, and those differences could relate to all kinds of background differences that are hard to measure, like access to healthcare, nutrition when they're growing up, quality of schooling, all the background things that could matter that we tried to get at some with our Hispanic groups are there, and it's very difficult to reliably and validly in a retrospective way with an interview find out all the things about people's backgrounds that could matter. I think as a clinician you do that and you make clinical judgment about how to weight those things, but to develop norms you have to ask the same questions of everybody and see if it matters and how much it matters with different groups. So it's not the color of the skin that matters. It's the backgrounds that matter. But it's really hard to get a 75-year-old patient to reflect and objectively measure what things were like when they were growing up and so on. And we don't have norms that get at that. We were aiming in that direction with the Hispanics where we were exploring what things did matter beyond our age, education, and sex. So there are a lot of things, and they're probably different things for different people.
Yeah.
So.
Yeah. Yeah, and you're really touching on a lot of things that have come through on the Q&A. And I think we all have been grappling with for a long time, and it's coming to a head of kind of understanding and deciding how we're going to move forward with race-based norms and trying to capture these differences. Like you said, that the color of somebody's skin does not matter, but their lived experiences do. And I think you touched a lot on approaching that in a new way with the norms that you were discussing later in your chat. But of course, we do have some people who are wondering what your thoughts are on, how this is playing out with retired NFL players and other ways of how we should maybe move forward to think about the way that we're crafting norms moving on.
Okay. So NFL is a complicated issue, and you don't know, but for many years when the Chargers NFL team was here in San Diego, I was their neuropsychologist, and so for several years we did. During training camp, we evaluated all the players and before they were injured, and then we established baselines, and we did that every year. And then we had some norms for change and such. And I can tell you that both within and across racial groups, everybody was not the same. And ideally, what we would like to have is we would like to have all people in any population that we are likely to see as patients have full testing prior to anything bad that happened to them or that may happen to them. We never had that, unfortunately. In the NFL, though, one of the things that bothers me about this whole thing is in the NFL, in many cases, if not most cases, they do. And now they're doing some more quick and dirty computerized things that I also work with them to interpret, although I didn't select them, and they don't have good norms, but everybody's results were used to compare, when they're not concussed to when they were potentially concussed. So I think I don't understand why most of these people don't have results from quite a long time ago that could be compared now, instead of just, when we do norms for change, we don't do, I didn't show you this, but the demographic corrections did almost nothing. The other factors accounted for the variance. So if you can compare a person with their own results from before to measure change, either decline or improvements, that is the best thing. And I have not heard anything about any efforts to look at that. But there are lots of variability. There's a lot of variability among NFL players. They're very similar in terms of they're all great athletes, and in terms of their football skills and all of that. Not necessarily the same for their cognitive skills, for all sorts of reasons that we've touched on.
Absolutely.
So again, both false positive and false negative errors are bad, in my opinion, and we should try to minimize and balance them both, and as best we can using. And it turns out that cross-sectionally, at least, if you account for these basic demographic things that are they're fairly easy to measure, but not necessarily easy to measure the background factors that may travel with them, you can account for a lot of variance, and you can reduce a lot of errors. And what they're complaining about is they're complaining about lack of sensitivity in their case. If you use race-based norms, you can get better sensitivity if you want to sacrifice specificity, but then you get the other argument. And I think depending upon your point of view and what you're experiencing, what your goals are. I mean, if you're in a forensic situation, a defense attorney would want you to call everybody normal, and a plaintiff's attorney wants you to call everybody impaired. The best thing in my experience is to try to balance them and be as accurate as we can, given the tools that we have, which are imperfect.
Yeah, absolutely. I have my eye on the time, and so maybe I'll ask one last question of you if you have the time.
Sure.
Um, as a segue, there's a lot of questions in the chat about following up on your work with Latinx individuals, and I think there's a lot of excitement about that work. And so just know that a lot of people in attendance are probably eager to hear more from the work coming on, and I'm sure that they'll follow up and read the papers that you referenced. But Dr. Jennifer Manley said she would like to know, what are your thoughts about the importance of region in neuropsychological test norms? And if you think it's a factor, and what is the best way forward for updating norms? Or how often should norms be updated?
Yeah, those are really good and difficult questions. First of all, the regional differences are, that's an empirical question. You could speculate about it, but there likely are differences in the case of Latinx. We know from our HIV work is there are differences from between those from originally from Puerto Rico that are living in the Northeast, and the more Mexican American background people that we have in Southern California and Arizona. And what that's due to is of great interest, but it needs to have good research, but unfortunately, the funding for such research is not easy to come by. I know Jennifer is doing great work with her population of aging African Americans, and that's wonderful. In general, our experience has been it's hard to get NIH to pay for you to get norms for us to work on our infrastructure in neuropsychology. But
So frustrating, isn't it?
Yeah,
Norms are so important to everything that we do, but the funding is just really hard to get. So,
right.
yeah. Well, thank you so much. I would just, on behalf of all of No Neuropsychology, we really appreciate your time in this wonderful lecture. I'd like to remind everybody that next week we'll be back with a lecture on the business in neuropsychology. I think that's a very important topic that a lot of times we don't get to cover in graduate training, so this should be helpful for a lot of trainees. Thank you again, everybody, and we look forward to seeing you next week.
Thanks, everybody.